Good morning. My name is Dr. Elizabeth Williams, and I'm excited to be here today to talk to you about a topic, urinary incontinence. Just a little bit about myself. I am a private practice urologist here in the St. Louis area. I did all of my training in the St. Louis area, including medical school and internship and residency. And then I spent 1 year in the Twin Cities completing my fellowship in female pelvic medicine and reconstructive surgery. I spend a lot of time talking to patients about incontinence and prolapse, and I'm excited to talk to all of you and give you more information about understanding this very common problem. So as far as our topics for discussion today, I'm going to talk about the most common types of bladder leakage, and I'm going to talk to you a little bit more about the treatment options. So first of all, what is urinary incontinence? Bladder leakage, which is also known as urinary incontinence, is the loss of bladder control or involuntary loss of urine. This is a really common problem. 1 in 2 adult women have reported urinary incontinence. In a separate study, 18 million women in the United States reported urinary incontinence. Now we're going to talk a little further about the most common types of leakage or incontinence. So there are 2 main types of urinary incontinence. There is what is known as urge incontinence and what is known as stress incontinence. Urge incontinence is the unintended loss of urine due to an involuntary bladder contraction. What that really means is that is the patient who says, the moment that I put my keys in the door, or I'm trying to get my pants down in time, or I hear running water, all of a sudden I just lose it. Stress incontinence is the uncontrollable loss of urine during some sort of a physical exertion, such as a cough or a sneeze or running or jumping. Quite a few of my patients have what is called mixed incontinence, and that is a combination of both stress and urge incontinence. So as far as looking at the breakdown between urge incontinence, stress incontinence, and those with mixed incontinence, looking at that study where 1 in 2 adult women reported incontinence, about 49% reported pure stress incontinence, 22% reported pure urge incontinence, and about 29% reported mixed incontinence. So urge incontinence is really part of a constellation of symptoms known as overactive bladder. Urge incontinence, a lot of patients will describe feeling like they need to go to the bathroom and having trouble controlling it and getting to the bathroom after having just gone. Overactive bladder is a constellation of symptoms including urinary frequency, nocturia, and urgency. Urinary frequency is defined as urinating 8 or more times during the day. Nocturia is voiding 1 or more times at night. And urgency is that sudden or strong desire to urinate. I describe it as going from 0 to 60. You don't think you need to go to the bathroom, and then the moment you stand up, you needed to go 10 minutes ago and you're rushing to the bathroom. Stress incontinence is the loss of urine during any movement that puts additional pressure on the bladder, such as a cough or a sneeze or a laugh, or running, jumping, lifting something, even vomiting can result in stress incontinence. Now, within stress incontinence, there's 2 subsets of stress incontinence. There is what is known as urethral hypermobility. That occurs when the bladder neck, and the urethra no longer have adequate support. The bladder neck and the urethra will move downward under pressure, such as a cough or a sneeze. The other type of stress incontinence is intrinsic sphincter deficiency. This is the inability of the sphincter muscle to close completely. And as a result, that causes the leakage. This can occur when the nerves that innervate the sphincter are damaged, when the sphincter muscle itself is damaged, or when the urethral lining is damaged. As far as potential risk factors for stress incontinence, there are quite a few. Age can be a risk factor, including postmenopausal state, pregnancy and particularly vaginal deliveries, hysterectomies or other pelvic surgery, Obesity or increased BMI. As you can imagine, you're bearing down with more weight or pressure on the bladder. A lot of physical activity or heavy lifting. My patients who have very labor-intensive jobs can be at an increased risk of stress incontinence. Smoking, and particularly that smoker's cough. There can be a genetic predisposition or family history of stress incontinence. Diet can contribute. Injuries to the pelvic organs or to the spinal cord, and other medical conditions such as diabetes can be contributing factors to stress incontinence. As far as mixed incontinence, again, this is the involuntary bladder leakage associated with a combination of both urge and stress incontinence. I do spend a lot of time in my office talking to patients who have who have mixed incontinence, making sure they understand that mixed incontinence really is a constellation of both the urge and the stress. And in order to adequately treat mixed incontinence, they really need to focus on treatment options for both the urge and the stress incontinence. So let's talk a little bit more about treatment options. I love that this slide says you don't have to live with incontinence. It always surprises me how many women think that this is just something they have to deal with or live with. I hear the words oftentimes, well, this is just normal having this leakage. I always tell women, what is common is not normal, and you do not have to live with this problem. As far as barriers to seeking treatment, less than 50% of women who do have incontinence actually discuss their symptoms with their healthcare provider, which is shocking if you think of 1 in 2 adult women have incontinence. And there's a variety of reasons as to why women might not seek help when they do have this type of incontinence. A lot of them are embarrassed or feel ashamed to discuss it with either their primary care physician or their gynecologist. Sometimes they're unaware that their condition has any treatment options. And again, a lot of them think it's just a normal part of the aging process. As far as urge incontinence and overactive bladder, there are a number of treatment options available. Several non-surgical options are available, including lifestyle changes, such as working on pelvic floor exercises and making dietary modifications. I talk a lot to patients about how much fluid they're drinking and the types of things they're drinking, including minimizing or eliminating caffeine and alcohol, which are the 2 biggest bladder irritants. There's an option for a formal course of pelvic floor physical therapy, which is done one-on-one with a pelvic floor female pelvic floor therapist and may include biofeedback. And there's also the option for a number of different oral medications for this problem. There are 2 minimally invasive options available, including Botox injections, which are done in the office, or posterior tibial nerve stimulation, which is somewhat similar to acupuncture. There's also a surgical option, including sacral nerve stimulation. Now let's talk a little bit about the stress incontinence. There are non-surgical options, including those pelvic floor exercises or those Kegels that your gynecologist may have spoken with you about. There is an option here for the pelvic floor therapy, as I mentioned before, along with some biofeedback. And there are also vaginal inserts, namely vaginal pessaries, that can be tried for stress incontinence. There are 2 minimally invasive surgical options, including injectable suburethral bulking agents and tension-free mid-urethral slings. There are also surgical options available, many of which are abdominal procedures, including bladder neck suspensions, Marshall-Marchetti Krantz procedure, and a Birch copal suspension. Mixed incontinence treatments involve really treating both the urge and the stress incontinence. And as I mentioned before, I really try to emphasize to my patients that if they really want to treat their mixed incontinence, they need to pick an option for both the stress and the urge incontinence. Who can treat incontinence? So your general practitioner or your family doctor is someone with a general understanding of incontinence, and they can prescribe medication or could give you a referral for pelvic floor therapy. A urologist, such as myself, is a doctor who has specialized training that focuses on both the surgical and the medical diseases of both the male and the female urinary tract systems and the male and female reproductive organs. A number of urologists have subspecialized training in female pelvic medicine and reconstructive surgery, and those are the ones that oftentimes will directly address incontinence. Urogynecologists are doctors who receive specialized training to diagnose and treat women with pelvic floor disorders. So, what can someone do who's looking to learn more about incontinence? Number one, they can learn more about the condition on a webinar such as this or going online. You can talk to your physician about the symptoms you're experiencing. And you can also seek out a physician who specializes in the treatment of incontinence. You can also consider going to the website www.chooseyou.com, and you can find a specialist in incontinence there. I do want to emphasize that all treatment options should be discussed with your physician with consideration for your individual medical history. Be sure you ask your physician about all the potential risks and complications regarding these treatment options before you guys formulate your individual treatment plan. I really appreciate you taking the time today to learn more about urinary incontinence. As if I can emphasize just one point, though incontinence is common, it is not normal and it is treatable. Thank you so much for your time.